Well, good morning, councillors. It is now 10 o'clock and we are live. So it's Monday the 17th of October, and can I welcome you and our guests to this morning's meeting of Staffordshire's Health and Care Overview and Scrutiny Committee. I'm your Chair, County Councillor Jeremy Pert. This is the first time in maybe 3 years that we've specifically discussed people as part of the Overview and Scrutiny agenda. We all know that people is the greatest asset that we have in any organisation, whether that's in health, social care or even within the County Council. And I just wanted to start off by reflecting what a tremendous job every member of health and care staff has done over the last 3 years, and we owe each and every one of them our thanks. Today, the objective is to familiarise ourselves with one of the three key issues facing our residents in the delivery of health and care services, and that's about how the system recruits, retains and trains, and as well as grows their staff. This is a huge challenge in the light of global labour shortages that are here for maybe the next 5 or 10 years. So please can I encourage members to be strategic. Let's not focus in on one facility or one small cohort of, say, 50 people when we're talking about 10,000 full-time equivalents in health and nearly double that in care. So on that note, welcome to all of our guests. Good to see you. Can I remind committee that today's meeting is being recorded, and for those who want to watch today's session back, the recording can be found on the County Council's website. The meeting is also being beamed live for people to be involved with and will cut off 20 seconds after the equipment has stopped. All voting committee members are in person. Apologies, we're still in the Oak Room. I'm promised that next time we will migrate to the chamber again. It's not so bad given the number of members this morning, but obviously if full committee was here, it would be more of a squeeze. So apologies for that. And obviously there's a variety of our guests who are in virtual attendance. Could I ask our guests to accept that the members have read and digested the papers? Maybe digested is a bit hard given the number of acronyms and abbreviations in them. So maybe I would ask that we don't refer to everything by abbreviation, because I didn't know half of them, I have to admit, and had to look up most of them. Please can we accept that members have read the papers and digested them, and can we restrict our comments in opening to 10 minutes, please? Can we also focus in on the tangible outcomes for the residents of Staffordshire? Let's use the data that we've got to provide assurance that things within the health and care system within Staffordshire are going in the right direction. So, thank you. On to item 1. First of all, apologies. Zach.
Good morning, Chairman. I've received apologies from Patricia Ackroyd, Philippa Hayden, Keith Flunder, Jack Abrahams and Lynn Hingley.
And I have Janice Sylvester Hall. Did you mention Keith Flunder?
Yes.
Thank you. So I think that's us. So on to declarations of interest. Do we have any declarations of interest relevant to this morning's agenda? Please, Councillor Anidler.
Thank you, Chairman, and good morning, everyone. Yes, I'm Partner Governor on the Midland Partnership Foundation Trust on behalf of the County Council. Thank you.
Thank you. Noted. Councillor Bernard Peters.
Staffordshire Local Authority appointed Governor at UHDB.
Thank you. Can I just confirm, Zach, that we are quorate? Thank you. Item number 3, the minutes of the meeting of Monday the 3rd of October. That's just a fortnight ago. I seem to see you guys more than I see my own family. So can I ask if the minutes are a true record of our last meeting a fortnight ago? For those of you who are there, thank you. Are we all in agreement? Thank you. That's good. I'm reliably informed that all actions have been followed up and information will be circulated as we go, as and when we receive that. So, item number 4, which is the ICS workforce. Am I handing over to you, Alex, or to Mish, or to both of you?
Thank you very much, Chair. Both of us, thank you very much, and good morning, everybody. I'm Alex Brett. I'm the Chief People Officer for Staffordshire and Stoke-on-Trent Integrated Care system, and I am joined by Mish Irvin, who is the Associate Director of People for the System and my deputy in this role. Taking the papers as read, and I know that you've got a number of things in your papers, which includes our people plan for the system and our annual report. I know there's a lot of information in there. So what we hopefully will do in this 15 minutes is just give you some key highlights and share some good news stories around the work that we are doing as a system together as partners to try and address some of the workforce challenges, but also think about how we develop as we go forward. So next slide, thank you, John. So just to sort of give you a bit of a summary, as you will all know, and it's why we're here today to talk about some of the workforce challenges and to talk about some of the planning that we've got in place to get us through winter, but also thinking about that plan going forward and around how we address some of the agency challenges and some of the growth that we need to meet to reach the position where we're filling our vacancies. And you will know from the reports, I won't go through them all, but we have a number of challenges around health and care workforce, some due to the impact of COVID. Staff are tired, our underlying vacancy position, which is a national problem, and then also we've got developmental monies to meet our operating plans. The NHS pension scheme has had an impact. We've seen an increase in turnover of people wanting to retire. And I know that Andrew is here to talk a little bit about the social care staffing situation, but also the care and nursing home staff and domiciliary care. We had the benefit of having the temporary register open for us during COVID, which has now ceased. And obviously we've got the challenge of winter and to meet that demand. So what we're doing as a system is working together. You've got the plan and some of the things that we've achieved over the last year. And Mish is going to take us in a minute through some of the things that we're doing now, but some key highlights on a couple of key programmes of work and also some staff stories. So with that, I will hand over to Mish. Thank you.
Thank you, Alex. Next slide, please, John. So yes, there's a lot of detail in the papers, but what we wanted to do was just to bring to your attention some of the proactive work we've been doing in the community. So from a recruitment and resourcing perspective, there are a number of events that have been carried out with numerous individuals that we've worked with, that we've made contact with, offered them opportunities, either in jobs or in work experience or volunteering to try and support them to come into working in health and care. You can see that we were at Pride this summer as well, so encouraging colleagues from lots of diverse and seldom heard backgrounds as well to come and work with us. If we go to the next slide, please, John. Engagement. So we're looking to really try and increase the number of people that want to work in health and care from the longer term. So there's the now, but there's also the future workforce. So we've developed and we've delivered a number of virtual work experience programs. So there's the mental health, the primary care that we've already delivered, and the acute has just been launched. So giving people the opportunity to stay from home, to be able to go in and reach into those settings and understand what it is to work there. That should then lead to them taking more face-to-face opportunities and hopefully careers in health and care. We're working with Cornerstone Schools, and there's a really significant project that hopefully you will have seen in the paper that describes how we are going to be working with children from primary school, so reception age, all the way up into year 11, to help them understand and drip feed each year and throughout their curriculum to understand what the science and what the opportunities are to work with us, so that all children from all different backgrounds can understand the careers and also not just think, well, it has to be nurse, it has to be doctor. Actually, there are lots of different roles available. The apprenticeship scheme, we've recruited 40 to our system-wide scheme, and we did win the National Apprenticeship Award for the West Midlands Heat last week, so really pleased about that, and we've got the national awards in December. That's a scheme that you'll see in the video. One of our colleagues is able to really bring that to life for you. We've also been sharing our apprenticeship levy, so NHS Trust do have that, and we're not able to spend all of that each year. So we've been sharing it with our private sector and primary care organisations to deliver more apprenticeships and more learning. If we get to the next slide, please, John. Retention is something that came up in the meeting I was present at a couple of weeks ago. I'm really keen to have a conversation with you about that. You know, we are really proactive in terms of this. This is one of the biggest risks for us. Alex has already referred to burnout. We have got a number of individuals that are also coming up to retirement age. People are tired, they're able to retire, and we're losing staff. We're losing staff more quickly, I think, at times in some settings than we're able to recruit. So it's a massive risk for us, and we're doing lots and lots to try and encourage people to stay and offer them different opportunities. Also to understand the problem. You know, work-life balance is a massive problem for us. And in terms of health and social care and the way that we've traditionally worked, we have to really challenge ourselves to offer different and more flexible opportunities for our staff if we want to keep them. So I'll stop talking. John, if it's okay, I'd like to show you two videos. One is from Philip Earlham, who is one of our staff that came to work with us as part of the pandemic response. He joined the People Hub, which is our system bank, and then since then he'll be able to tell you the career that he's decided to come on to. The next video is about our apprenticeship scheme and hopefully should speak for itself. We don't have the sound, John.
My name's Philip Earlham. I'm currently a vaccinator on the People Hub. My background getting into the People Hub, it's a story that goes back to the start of lockdown number 3. So I'd been put on furlough by my current job at the time, which was retail sales. I had no experience at all at that point in anything medical, but I didn't want to spend months and months and months doing absolutely nothing, so I thought, why not? My first shift at the start of February was at Daniel Platts within Staffordshire. I found the staff there brilliant, especially coming in as someone that didn't have any clue anything medical. All the staff there were so inviting, so supportive. On my first shift, I was encouraged by the powers that be there and the staff to get myself signed up to the People Hub, which is what I did. Recruitment process was very, very easy, very straightforward. Didn't take too long. Put my application in December, got approved in January. I did manage to get all the training done online that I required to do. I got myself signed off to get involved with the younger children, and I did. And I have done some shifts at Daniel Platts vaccinating children. That led me to get invited by the team at the People Hub to train as a care reservist, which I did. Put my application form in, had an interview, very, very straightforward. Got taken on, went through all the training online for that, and again I found that really informative. In the interim, while I was doing all of that, I was exploring the possibility of getting more involved with the NHS, because sort of getting involved with the vaccine programme had given me the bug. So my journey's gone from volunteer at St John's to being involved with the People Hub as a paid vaccinator, trained up to be a care reservist, and then that's led me to be a trainee mental health and wellbeing practitioner with CWP. It's a hell of a journey. If you'd have told me 2 years ago this is where I'd be, I would not have believed anyone. It's been invaluable, and that's led me to this point. So I'm now in place within community mental health trust. Everything that's led me to there starts with Staffordshire. Even though I wasn't with the People Hub at the start, it's just that sort of friendliness, that openness about my first initial contact helping with the vaccine programme during that February, March and April. Without that, I'd have given up and just done nothing. But because I had the warmness there, it's led me here. I'm told, and I can see it, that I should be helping a hell of a lot of people once I get fully trained up. And it's down to you guys for giving me that opportunity.
Thanks, John. And the next one is about our system-wide apprenticeship scheme.
My name is Adil. and I'm one of the apprentice students working as a healthcare. My first main placement is STU and UHM hospital, and I work for assessment unit, specialized decision unit, where we look after 5 different specialty. So we have ortho neurology, which is great, and stroke. So it gives me 5 different experiences. Also, I've been given more opportunity to do like more than a carer, do like blood pressure, doing bloods, doing blood scanner. So it's more like more than doing a carer, doing a lot of things you can do. And I like that because it's a busy setting, everyday patient coming and going, and just amazing. I would say that's one of my best placement I've done. I was studying healthcare college, doing level 2 healthcare college, and I was more interested to do more practical, and where I was being given an opportunity to do a traineeship where I can get apprenticeship. Got apprenticeship and had an interview and I passed it. And since I'm starting working and also studying, it's more suitable for me to work and have that experience before finish my qualification. Help me in different ways. As I'm come to this country as a migrant, so I was being looked after while I was a child and been in other countries, and I was brought here to develop and make a better futures. Because I'm 20 years old, I like things to be done more practically. So that's what I've decided to do, apprenticeship, to have a short way but work while I'm learning as well, to be more stable. I would say a piece of advice for any young adults who's willing to work in the healthcare setting, it's a great opportunity to take. You get paid, you've been supported while you're learning, while you're studying. On the job, you've been taught how to undertake, gain the responsibilities, get standard levels of experience, and a lot more that's waiting. Anyone, I would say the journey is very beautiful from start to the end. You get loads of opportunities of working in different settings. It's quite optional. You meet new people, different languages, different cultures, and different settings, and you will learn a lot to be learned. And you can also, in the meantime, you will be able to support more people while in your journey. I would say it's been really great since I've started. I have no issues. IC has been great with the times, placements, studies hours, college, all been very useful and been done by the time. Since I've started it January till now, I didn't have any problem. So it's great. I've chosen this because you get paid, you work, you have study hours, so it's amazing. And then probably you have an optional time. If you want to overtime work, you can join the bank and explore a lot more. And it's really beautiful journey. By the time they comes very poorly, unwell, and by the time they're leaving, like they're very fit, they're healthy, they're saying goodbye, and they, they're happy to leave, and then you feel sad about them while they're going. So it's really beautiful why you care. It becomes a very good relations in the meantime. So I would say it's beautiful, yeah. Hope I passed my maths and English and willing to work in the future as a nurse. And I have gained some qualification that I need for that and some experiences, and people that I've worked is willing to with me help me with that to get through that as well. While will be supported while I'm doing apprentice student, people support me to get to my purpose and aim that I need to done and get my diploma done.
Thank you, John, for that. And hopefully you enjoyed hearing some real stories of some of the people that have worked within our integrated care system and taken advantage of the programmes that we're working on together collectively as a system. So that leads me nicely into our final slide, which is really a conversation, hopefully with you and some questions, and really seeking your support, I guess, in terms of the conversation going forward around the work that we're doing together, really encouraging people to come into health and care careers, and obviously we're keen to work with you together going forward. So thank you for your time, and we'll stop there and take any questions. Thank you, Chair.
Thank you, Alex. And Mish, obviously, sorry. I'm looking around the room and I'm not seeing... Jill Hood. Always rely on Jill. Thank you.
Thank you, Chairman. Well done, Adil. Absolutely splendid to see this young man so keen to learn. It fills me with hope that this is the calibre of people who are coming forward. I can't say the same for the previous young man, who seemed absolutely delightful, very, very keen, obviously coming forward as a volunteer. It fills me with dismay that the mental health services seem to be flooded with trainees at the moment. And all that came over to me from that video, yet again, another really pleasant young man, is that, when I get trained up, I can't wait to get going. This saddens me. I deal with a great number of people who are being let down by the mental health services continually. Trainees, telephone calls, tick boxes, people who've had no experience of life whatsoever. And I just think that we should be putting emphasis on the training for going into the mental health. It just seemed as though it was, that's what I've decided and I'm going to train and that's what I'm going to do. I'm sorry that it's come over that way to me. And, well, it worries me. I have great concerns about this. So I do apologise for sounding so critical. I just, somehow I couldn't take it seriously. Thank you, Chairman.
Thank you. Who wants to pick that up? Mish, Alex?
Yeah, I'm happy to come back in, and thank you for your comments. And I'm sorry to hear that it came over that in that way. I guess probably what you don't get from the video is some of the backstory of this young man. He has got quite a lot of life experience, and actually a background that means that he has got a lot to bring to the role. In terms of mental health services, and perhaps what you didn't get from the video clip was his reason for why he wanted to go into mental health services. So I'm happy to pick that up behind the scenes, but something that we're not doing is just bringing people in and siphoning them through. That, you know, they do have the wraparound support, the training, and he is on a serious programme of work to get him into working in services, and he is really committed. So apologies if it came over in that way. It wasn't meant to, and obviously there is a fairly significant backstory to that video, which perhaps you didn't see. Thank you, Chairman.
Jill.
Thank you for that explanation, and that seems quite a lot clearer. I think it was a little remiss not to have had this young man just to give just a touch of his background. He gave reasons of being a vaccinator. It almost seemed as though I'm good at vaccinating, so I'm going to go into mental health. But thank you very much for your explanation.
No problem.
Thank you, Charlotte.
I mean, clearly one of your issues is staff retention. And on page 16, 2.22.3, you talk about offers to incentivise staff. So I'd like to hear more about that. But also you talk about, on page 22, financial resilience toolkit, tip for managing personal finances. Well, we heard from University Hospital of North Staffordshire, or sorry, Royal Stoke I should call it, that many nurses are using food banks. So does your resilience toolkit also include signposting people to food banks? And thirdly, you're talking about international recruitment of nurses. And that worries me a bit, because obviously one of the issues about recruiting internationally is that you're denuding those countries of nursing, of skilled nursing staff. And we've seen it with doctors. and we're seeing it with nurses. And it just seems to me that as always, rather than training our own staff, growing our own community of health professionals, we're relying on other countries that can least afford to lose staff, and we're poaching them. So I'd like comments on all those three, please.
With you, Alex.
Yes, thank you very much. And Mish, chip in as we go. You might want to add additionally, so do come in. So the first one around retention incentives, I think what Mish articulated was we have a huge challenge in both health and care. And one of the things that we're trying to work on collectively across all organisations is what's attractive about coming to work with us, you know, what's attractive about coming to work in health and care, and really thinking about that career. So a lot of work around career pathways, but also thinking about meaningful jobs and what does the health and care sector have to offer. And I have to say, it's not always financial incentives. When we talk about incentives, we are part of a national pay framework, so it's not necessarily about that. Some of it is about qualifications, training, pastoral care, jobs that interest people. And I know Mish will want to expand on that one particularly, and then I'll come to the other two questions. Thank you, Mish. Do come in and add.
Thank you. And thanks for that question. It's something that, as we've mentioned, that is really important to us. From an incentive perspective, what we need to understand is actually what will incentivize different groups of staff. Not everyone is the same, not everyone has the same priorities, and therefore we've invested as a system into individuals that will work across the organisations, both in health and care, to understand exactly what it is that is going to incentivise different groups of staff to continue to work with us. So for some people it might be training, education, development. For some people it's the flexible working piece. So trying to offer different shifts. And for some of that as well, it's the cultural change that's required for managers to understand that that is necessary. We can't continue to ask our staff to work those long shifts, to not be able to book holidays because the rotas aren't set in a certain amount of time, to allow people to be able to pick their children up. So for some people, it's about flexible working. For some people, it is about financial incentives. So with the cost of living increases, we are considering where we can incentivise our colleagues to work additional shifts or to work out of hours. However, it will help them to meet their own life balance that they will need to have. And I think in terms of the retire and return, we're doing a programme where we'll be offering colleagues the opportunity to come back, but work in a different area, or to work in an educator role, or to go into schools and to talk to kids about their roles. So still valuing what they can do, but in a different place, perhaps under a little bit less pressure. We're doing these things called itchy feet conversations, career conversations. We're having seminars to help to educate everyone about actually there are different roles in different organisations, and that we're not so much bound by our organisational boundaries that people can't have different career pathways. So creating things like rotational posts, secondment, more flexibility, so that again we can create more of a peripatetic workforce which will benefit ourselves and our patients, but also for them that they have that job satisfaction because they have more career development. So there's a number of different things that we're trying to implement. It's a really, really tough challenge, and it's not going to be one size fits all.
Thank you, Mish, for that. And the addition, sorry, apologies.
Carry on, I was just thanking Mish for that.
Thank you. The second question, which was around obviously financial well-being, this is something that we're all taking extremely seriously. It's something I think that we haven't had to think about in this way previously, but we are now, and you mentioned there around food banks. One of the things that we're doing together as a collective of organisations is thinking as much about financial well-being as we are around health and well-being. And we talked a little bit about how tired staff are, and this is an additional pressure for a lot of staff. We're working very closely with the Citizens Advice Bureau, and we have got a number of things in place, I think, across organisations to help staff to think about their financial well-being, which might be accessing things like hardship funds. It might be thinking about mileage rates. You talked a little bit about signposting arrangements, and we have a plethora of agencies that we're working with to help to support staff. The other thing I'd just add in addition is that we've also got a psychological wellbeing hub that is within our system now, which all staff can access, which provides psychological support. But of course, the financial pressures that staff are facing are particularly difficult, but there is a range of support in place for people, and happy to share that if needs be. I'll just move on and answer your third point around international recruitment, and I know Mish will want to come in addition to what I just say as a lead in. I think the concerns that you've articulated there are things that we ourselves are very mindful of, as is the NHS. And I think, hearing the chief nurse talk recently nationally, it is something that we are particularly cautious about in terms of how we do international recruitment. The guidelines around ethical recruitment and not taking or bringing staff over from red list countries. So I think it's fair to say we're not seeing this as the solution. We're seeing it as something that can sit alongside the other actions that we're taking. I'm not seeing it as the thing that we need to do en masse, but rather where there's an opportunity to do it ethically, to do it in the right way, we'll explore that. I know our acute colleagues have been doing this for a number of years, and we are exploring it. But Mish, do come in addition to that.
Thank you. And I think in comparison to some of the counties and systems in the UK, we are relatively low in terms of our numbers of international recruitment. And there's a few reasons for that. Staffordshire is not a county that has a high ethnic minority population. So on that basis, it's much more difficult to be efficacious in regards to international recruitment. When we bring colleagues in the past, there have been concerns about numbers of individuals that live and are like them in the community, and there's been attrition because of that. So actually, international recruitment in our county it's there and we're doing it, but it isn't as high as certainly other more inner city areas like Birmingham, North Birmingham, Manchester, for example. Just like I said, for retention, it isn't a one size fits all with recruitment. What we're trying to do is lots of different approaches to increase our current workforce as well as the future workforce. I've touched on the future, but from a current perspective, the fact that we have a system bank, we have the people hub, that's a workforce that we've created from nothing, that wasn't in place at all before the pandemic. We are now national exemplars for this model, and it's being replicated elsewhere in the country. We are the national exemplars and lead system for reserves as well. So you'll have seen in the paper a number of different types of reserves that we have. And what we're trying to do is offer that pastoral support, the flexible working, the recruitment events. We're doing lots of different things to increase our substantive workforce, as well as international recruitment being one aspect of that.
Charlotte.
I'll just come back. If you're not recruiting from red list countries, where are you recruiting from, and how many normally do you get coming on an annual basis to Staffordshire? That's the first question. And in terms of the second question about financial hardship, what sort of proportion of people who are leaving give financial hardship as one of the reasons? And are you finding, for instance, that a number will go and work in the retail sector if that's paying more and is less stressful than working in the NHS?
Thank you for that. And just on the international recruitment point, Mish, do come in, because I know that you've been close to colleagues who've been doing this. Today, it's been particularly within our acute trust who have recruited internationally, so UH&M and the big acute trusts. And I think to date, we've had about 100 a year, mainly from India. But I think this next year, we're doing a programme of work with NHS England, and that's across our 2 mental health providers, and that will be 10 in one organisation and 10 in the other. So that's sort of I guess the background to that. Mish, anything to add on that in terms of?
Yeah, I mean, only just to say it was those 2 years. So we've recruited 100 last year, and the target is another 90 this year. So relatively small numbers.
Yeah. Thank you for that. And could you just remind me? Yeah. Oh, yes. Your second point was around turnover and around financial hardship. I have to say that the biggest reasons that people are leaving are around flexible working and work-life balance. So we probably haven't seen it. I think in terms of it coming through in the data in large numbers, it's more about work-life balance and flexible working. That's not to say that we're not getting staff expressing concern around hardship, but what we're trying to do is provide that wraparound support to people to make sure that they're supported in the workplace, and we are trying to find solutions to that as employers. Of course, as public sector organisations, there's only so far that we can go in that space, so what we're trying to do is make sure that staff have the support, and we can signpost them to organisations that can help. And part of that is working very, very closely with the Citizens Advice Bureau as well.
Thank you, Charlotte.
Thank you.
Mike Wilcox.
Thank you, Chair, and good morning both. Just wanting to try and understand the workforce metrics that you've got at 3.3. And given the days lost to sickness, I just wondered what percentage of those days are to long-term sickness that you perhaps are addressing in a different way. Secondly, what sort of duty of care do you put? And obviously these people may well have been in the area some considerable time, so perhaps are well experienced members of staff. And then if you look at the actual people who are leaving, it seems to be that the additional clinical services, at 9.4%, seem to be the highest sickness, and they seem to be the people who are also leaving the organisation. So I just wonder if there's any correlation between what is happening there, whether it is to do with pay or conditions. And then, as I say, just looking at the sickness, what percentage of the days lost are to long-term sickness? If there is an issue with long-term sickness, what sort of measures are you taking to sort of address that? Thank you, Chairman.
Alex.
Thank you very much for the question, and a great question. And I don't know, Mish, whether you can drill into the data in a minute around, I guess, some of the metric conversation that you've had. And thank you for that, because this is something that we're extremely mindful of and is quite an issue in both health and care around sickness, particularly through COVID, where we've seen that peak. So some of what we've got, we tend to have a much smaller percentage of sickness, around about 10% of the 3% is normally around long-term sick, and can be really complex issues. And we do have some staff that we have got long COVID, and therefore we've seen that increase a little bit. Our two sort of biggest reasons for sickness in healthcare organisations are musculoskeletal issues, and therefore part of the wellbeing package that we've got is very much around fast-track physio, and really trying to get people back to work as quickly as we can. So tends to be what we would call, bad backs and that sort of thing when we talk about musculoskeletal, but also stress, anxiety and depression. And it probably links into the presentation that we gave in the first slide around the pressure that staff are under. I have to say, what we do see is that it's not all work related. A lot of staff have got some fairly complex issues going on outside of work. We've touched a little bit on cost of living, but we saw an increase in terms of family dynamics and issues there through COVID and through lockdown. So there are some challenges around sickness, and we all organisations have fairly robust offers around occupational health services, but also psychological wellbeing and things like fast-track physio to try and ensure that staff have and you talked a little bit about the duty of care, but the pastoral care wrapped around them. And we are working together collectively to ensure that we've got that consistent approach to how we manage, but sickness and absence, but also how we support staff. Mish, anything to add on that first point, particularly on the metrics? Anything you want to add?
No, I think, in terms of that breakdown of the long term and the short term sickness, absolutely, Alex. It's around about the 10% mark, and it is much more complex. The long term sickness management, the psychological health and well-being hub is something that we have in the system to support colleagues to have conversations and to be offered counselling or whatever it is that would support them. And I think that's something that really adds value, that we can all access health and care. Colleagues can access that. I think from the query around the additional clinical services and is there a correlation between the sickness being high and the turnover being high? Absolutely, and well spotted. We've noticed that as well. And this is our healthcare support worker, our technician workforce, those colleagues who sometimes, we do big recruitment events as the NHS, and those metrics are just NHS metrics that you're reading. You'll have read in the report that we are trying to engage and have more of our social care metrics in there because it's so vital. But the ones you're referring to are the NHS, and when we recruit healthcare assistants, sometimes there isn't a turnover then, there is higher sickness because these colleagues perhaps don't understand the work and the world that they're coming into. So what we're trying to do is to support them with placements, volunteering, work experience, the pastoral support wrapped around them prior to entering our workforce, so that we don't have the attrition following training. But yes, it is an issue. It's an issue for lots of reasons. And I think that in terms of the cost of living as well, I think colleagues are balancing off working in health and working in, as mentioned by our other colleague, in other settings, which they may feel has more remuneration and actually a little bit less stress. So again, it's about that incentivization, offering them something that will feel like a career pathway so that they can see that in time they'll be able to develop into registered roles that has got more remuneration but also more job satisfaction. So it's one of our retention pillars.
Mike, can I just ask a supplementary then? I seem to recollect that about 10% of your new recruits leave within the first 12 months. So a lot of time and effort goes into recruiting people who then choose to go and fulfill their careers elsewhere. What are you doing looking at mentorship or mentors, peer mentors in the workplace, and not just across the new recruits, but across everyone? Because it seems to me that it's an option to try and keep your staff close.
Thank you, Chair, for that question. And that links very much into the retention work that we're doing, but all organisations are looking at this very seriously. I think all organisations have recognised that that's a high figure for people to be coming in to health careers and then leaving. And as you've rightly noted, tends to be in those additional clinical services, particularly our healthcare support workers type roles where they're coming in and not always realising. So a number of things are already in place. We've got a fairly robust programme of what we call preceptorship for newly registered professionals, and what we're wanting to do is expand something similar out to others, having buddies in place for individuals. But the whole sort of wraparound support within that first 12 months is critical. And of course, where things are really pressured and difficult, particularly in clinical areas, and they're short-staffed, I think the time and ability to be able to do that gets stretched. So the work that we're doing at system level, and Mish will want to come in, I know, because this is something that we're really taking very seriously, is how do we put that in place across the board to make sure that individuals that are coming into roles know what it's like, have that experience. And I think Mish has just talked a little bit about that, but also that they have the day-to-day support when they're out there doing their jobs in practice. And that's the work that we're doing to ensure that, we keep the people that we recruit and that they don't go and leave us within that first year. And it is critical. Mish, do you want to add to that?
Yes, thank you. And not to repeat anything that you've said, so I'll just talk about the clinical placement piece that we're doing. So as in addition to all of that, what we're trying to understand is what capacity do we have to offer people clinical supervision in the system at the moment, and then what do we need to put in so that we can increase the amount of supervision that colleagues have. As Alex said, when things are busy, those things do tend to go off the boil. And our clinical and education piece is so important in that, from mentoring, clinical supervision, that resilience piece, and also the career development. So we're trying to do a piece at the moment where we understand our current capacity, and then we'll be able to try and put something in place that will offer additional capacity going forward. Now, I'm realistic in this. We have got a lot of clinical workforce that are incredibly busy. But again, how can offering clinical supervision to someone else offer job satisfaction to the person doing it? So we're trying to see it in the round as part of the entire retention piece.
Thank you. Appreciate that. Bernard Peters.
Thank you and good morning. My division is East Staffordshire, and I'd just like to frame my questions around East Staffordshire, if I may. I'm looking at the top of page 15. The final words in the paragraph, by doing this, we will ensure our workforce reflects our population and has technology and digital means, etc. Now, you will know that East Staffordshire is a very diverse community, and that might just clash with something that Mish said a few moments ago, that Staffordshire isn't a particularly ethnic-related area. And that made me feel a little uncomfortable, really, because I got this feeling, again, that maybe East Staffordshire had drawn the short straw. So the question is, how much resource and how committed are you to delivering that comment there about the workforce reflecting the community? And I'd like to leave this meeting today with a feeling of pace, because the several sessions that I've been to recently, I don't really get that. I know you're in a transition and we're trying this and trying that, but I'd like some reassurance that pace is in there somewhere. And how will I be able to recognise in the next 3 to 6 months that you are moving at pace? And I'll leave it there for the moment, if I may.
Thanks, Bernard. Alex.
Yes, thank you for that question. And of course, these staffs, it is part of our geography and is part of our system. And what we do very, very proactively and closely is work with our Derbyshire colleagues as well, and we work very much hand in hand with our Derbyshire colleagues, particularly around the Burton area as well. So I just wanted to make that clear in terms of the report. And I think, as you've rightly said there, that, we do have communities that we need to make sure that we are working proactively with, and that they do reflect that our workforce reflects our populations. And that is very much the work at system level, but particularly within our provider colleagues, because of course the work that we're articulating here is the things that we're doing together across the piece. But I know that within each provider they have what's called our workforce race equality scheme, and each provider within our geographies have that workforce race equality scheme, which is a legal duty to achieve, and have the plans around that, which articulate exactly what you suggested, is making sure that our workforce is representative of the communities that we serve, but equally that we're outreaching and working with our communities, and particularly for us around employment. And that's absolutely part and parcel of what I hope you've seen in our annual report, which in terms of pace, as you've said, we've only been in place as a sort of formal organisation as the Integrated Care Board since the 1st of July. But we've been working at this for some time as system partners, and I hope that what you'll see in the annual report that you've also got in your papers is about what we achieved last year and how we are moving forward, and with things like our apprenticeship scheme, working out into those communities, as Mish has suggested, through outreach work, and really making sure that people in our communities are coming into roles within the health and care sector. And Mish, do you want to say a little bit about recruitment events and actually our outreach work into communities?
Yeah, absolutely. And actually, just to kind of, in terms of the way that we build our scheme, so for example, the apprenticeship scheme, we've had a number of conversations with groups that are represented by seldom heard communities to help us to understand how best to target and create a pathway that's actually going to be something that is that actually appeals to people from seldom heard communities. This is something that we're really, really conscious of and want to do. So our apprenticeship scheme, as you've seen, is an incredibly diverse scheme. So we're really proud of that and the way that we're doing things. In our recruitment events, again, we will travel all the way across Staffordshire and Stoke-on-Trent to make sure that we reach all of the different communities that are there.
Thank you. Bernard? Can I just pick up, I think Bernard's point about sense of pace, I think is fair, because there was a people strand as part of the STP, and I wonder whether we're just close enough to the detail as to what is being delivered on the ground on a regular basis, and maybe that sort of is a sense that we should maybe invite you back again in 6 months' time, because it is one of the key issues, and we need to see sort of those step changes in delivery, and I think that would be fair. Rosie Claymore, please.
Thank you, Chair. Is that on? Yeah, okay. Thank you, Chair. Yeah, I was quite interested to listen to the young gentleman talking about apprenticeships, but if I could just go to the other end of the scale where you're talking about retire and return, I'd like to know how successful that has been, and if any work has been done into, I'm assuming that people are wanting to take an early retirement. If that is the case, has any work been done into why these people want to take early retirement? Is it pressure of work? Is it financial? And just another comment, have you looked at flexible retirement where people retire and then they do a couple of days work at the same time? Thank you.
With you, Alex.
Yes, thank you very much for the question. And I think it's a great question because it's really pertinent in the current climate. So what we have seen since COVID, but actually probably before that we knew it was coming, is that more people are retiring probably than they ever have. And there's twofold reasons for that. One is that we have what we call an ageing workforce. So the age profile of our workforce is that we have a significant number of our staff that are in that bracket of over 50, some with, if they work in certain professions or certain services, they may have special class status, which allows them to retire at 55. But what we've also seen is a significant increase during COVID, and actually from sort of the end of March, April this year, when the NHS pension changed and the rules of retirement changed a little bit for certain schemes. So we saw a significant increase there. What we've also not got is the same supply coming through at the other end in terms of our entry level roles. So actually what we've got is turnover here at retirement age and not as many people coming through, which is the thing that we are trying to address in terms of our supply, which we've talked a lot about today. In terms of retire and return, I think what we've all had in different organisations is organisations looking at that themselves. So somebody decides to retire, can we accommodate them? Can they come back and work a couple of days a week, which you've just articulated around flexible retirement? And I think we've enabled that for a number of years in our own silos and our own worlds of work. What we're trying to do is on a much sort of bigger scale, really, and give people a range of opportunities in terms of being able to come back and work flexibly. Some of that is through schemes that Mish has articulated around the People Hub and the reservist model, but equally that we're working together across organisations where people may want to take the foot off the pedal a little bit, may retire, or may actually just want to reduce hours prior to retirement. to do is think about how we accommodate that across organisations and across systems. So if one service can't accommodate that, or one area, that we look much more broadly and widely about how we enable people to retire flexibly. Mish, anything to add that I've missed?
I mean, you've really covered it there, Alex. Thank you. But I think just to say that we do acknowledge that this is an area of growth for us. You know, I think in the past there has been an interest in flexible retirement. There has been retire and return programs in place. It's not being structured in a formal way, though. So it has been applied, but perhaps in a more ad hoc fashion. And as Alex has articulated, not necessarily in conversation with that individual about what is it that would suit you. So someone that works in a really busy acute ward area may not want to return A, at that same grade, but B, in that same area. They might want to do something really different. And to understand what that might look like is something that hasn't been easy for them to access in the past. So that's the project that the team are working on at the moment.
Rosie?
That's fine, thank you for that. Thank you.
Just on that last point then, Mish, just very quickly, because time is against us. Can you do that on an ad hoc fashion, or do you need NHS, E&I, or whoever it is to lead on this?
No, I mean, we're doing it within the system. It is actually something that nationally they are focused on as well. So that, you know, all the challenges that we've described from a workforce perspective are national challenges. They have articulated that retire and return is a scheme that they would like us to develop. However, we can do that locally ourselves, and what that looks like and feels like has to be owned by our partners. It has to be developed and then delivered by partners. We are a small function, so actually it has to be something that's embedded within the culture of the organisations for us to get the tangible outcomes we're looking for.
Thank you. We obviously look forward to seeing that in due course. Richard Cox.
Thank you, Chairman. My question is partly has been answered throughout this morning's questioning, but I just want to try and drill down to something, if I may, and that is obviously the recruitment and retention, in particular, to the midwifery service. I particularly raise it in a sense to the pressures that the district that I live in, Lichfield, and I don't want necessarily specifics because I know that it applies elsewhere, but when we're looking at recruitment and retention, we seem to obviously have a link to that sickness and early retirement and et cetera, et cetera. And it looks to me, obviously, we're heading towards what we would probably proverbially call the perfect storm, where we are unable to actually carry out a service, full stop. And I was wondering what thoughts were around that, to avoid it, because obviously that's going to be a bad place to be, and not just on maternity areas but on others, even on our GP services and so forth. I don't know whether you're able to expand on that. Thank you.
Yes, thank you very much for your question, and I know Heather is also here waiting in the wings and has an agenda item, so it may actually be something that Heather may pick up on as well in terms of maternity services specifically. So yes, it absolutely is a perfect storm, and there are significant challenges both locally but regionally and nationally. So we are not exempt here, and that's why, you know, we're trying to do the programmes of work together collectively to find joint solutions. So one of the things that we did during COVID that is standing us in good stead in terms of addressing some of the workforce challenges, not all of it, but you've got obviously the plans that are in your pack, and some of what we're doing together is the formation of our people hub at system level, and this was born out of COVID. And what we did during COVID was come together as system partners to think about the workforce challenges collectively, but also to grow what we call a contingent workforce that hovers above the system in terms of a group of staff, some of which they've come from different sort of backgrounds, but you know, quite a lot of them are people that are either training students, some of them are people that have retired and returned. So we've got lots of experienced people on there as well who perhaps don't want to work full-time but are happy to come in and do some shifts. And what we've been able to do during COVID, when we've been really pressured, is mobilise staff across boundaries and actually try and support staff into supporting areas of greatest need where and during COVID an example would have been critical care. Now, of course, your question specifically relates to maternity, and obviously that's something that's really pressured that I think Heather may well pick up on, and a number of things hopefully you've seen in your pack, which is things like growing our own and our apprentices, which is a longer term solution in terms of how we grow our own. But equally, I know that Heather's team have been very proactive in actually working across boundaries and going into places like UH&M and services to support them when it's been really difficult, and actually going in to walk alongside and be part of the workforce in those areas. So it's something that's risk assessed regularly. It's something that we know is there. It's something that we are working on to try and address, but there is no doubt about it. The workforce challenges are significant, and that's why we're trying to work on them collectively. Mish, is there anything else you'd like to say in this space?
Just in relation to building the new, a new maternity workforce along with retaining our current workforce, we're trying again, it's no one size fits all to recruit colleagues from there is some international recruitment for midwives, and we've got a lead specialist post in place to support that, to ensure that we have the right individuals and that they're supported in the right way. We're also creating a midwifery apprenticeship, and we've also got maternity support workers. So again, encouraging colleagues to come in that may not have the traditional midwifery degree pathway, but are able to then learn over a number of years to become a midwife. So we're trying to increase every possible avenue for our midwifery workforce, but do acknowledge it is a high risk area, and therefore there's high scrutiny over that from the ICB perspective.
Thank you, ladies. We'll pick up with Heather in a minute, if we may, please, rather than through this session, just because time is running through. Richard, do you want to come back on any of that, or do you want to pick up any comments as part of the next section?
Yeah, if I may, the only other comment, and I understand we will pick up later, the only other that I'd got was obviously, again, around what you can do to make it a better place to actually work. And obviously people retire for many reasons, but one has to look at the situation to say, are they retiring and taking that option at 55 because, and it will soon be 57 in a few years, but would it be that it's because they just have had enough within the system rather than actually, I'm getting near that retirement age? It's otherwise creating those initiatives that make it still an enjoyable place and that to work in, and in terms of the work environment.
Thank you very much for that question, and that really is the whole premise of our people plan, which you've got in your packs, which is precisely that, and our vision around making Staffordshire and Stoke-on-Trent the healthiest place to live but to work. And a number of things within that. So we've talked a lot about the schemes and the work schemes, but equally what we've got that also sits alongside, which you may have seen in your packs as well, is how those people are led and managed. So making sure that we create the right tone, the right culture, that we make it an attractive place to work, that people want to come and work here because actually they are valued, they are supported, they have the right care around them, and that they've got fulfilling careers, so there is a whole, I guess, a whole package of things that people need to enable them to feel valued at work, Some of that is around the training and development they receive. It is about how they are supported by their managers and their leaders. It is about the organisations that they work within. And some of that is the wider actions that we're also taking, which is I guess the cultural stuff as well that sits around this. You know, having fulfilling career pathways. So what Mish has just described there is being able to come in at an entry level, at an entry level post, but then being trained and really working your way up to become a midwife, or actually to, you know, have that real pathway that enables you to have a lifelong career in health. That I think we have still got some work to do, but is very, very much part of the central pillars of the people plan around how do we enable that to happen, and that's the work that's taking place.
Thank you. I think Richard's happy with that. I just want to keep us moving because time is very much against us. I've still got 3 questioners, so I don't want to take any more questions than the ones I've already got. I would just make one point in your answer, though, Alex. We want to create career paths, yes, for health, but also for care, and interchange between the two. And if we only focus in on care and on health, I think we miss half the challenge, because whilst you may only have 11% turnover rate and vacancy rates very similar, care has got a different set of those. So please don't forget that. Let me just move on to another questioner, please. Phil Hewitt.
Thank you, Chair. I'm going to be try and be brief. I'm not always very good at that. Thank you. Because a lot of the questions, we're starting to duplicate the questions, aren't we, really? And I have to say, firstly, can I say, I'm enthused that we recognise there's an issue. And I think we've been a long time getting there. So I sit here thinking, at last somebody recognises it's an issue. And I'm going to be a little bit parochial because I know somebody that worked in the care industry, is it in industry sector? My apologies, for a number of years. And one of the challenges that they had was sick of working every Christmas Day, sick of working Sunday after Sunday. And one of the feedbacks when I asked why they left, they said was they didn't have any children, so they were rotated on every Christmas Day. And the answer was, well, you don't have any children. So after the 5th Christmas Day, they decided actually they'd leave the sector and went on to do something else. So this is my question, because I think you've answered generally that you recognise those things. So it's my question is, are we, and I presume we are, doing leaver interviews? Do we get down to some of the real detail on that? Because I've read the papers and I've read the percentages that leave, and I read that. I worked in an industry that nobody left. So when somebody did leave, we could say, whoa, that's a bit of a shock. Why have you left? So if the person I'm talking about had a leaving interview, she may have stayed. Because in reality, it actually said, I'm entitled to a Christmas Day as somebody who's got 2 or 3 children. You know, maybe or maybe not, that could be argued the point. You know, I'm entitled not to be rotated on every Sunday. Because my sympathy, to some extent, was also with the person that was rotating on, because they had to fill a rota, didn't they? So the challenge is twofold. So are we also supporting the managers that have to force the issue on this? The chairman's nodding at me, but I'm still going to carry on. Are we supporting the managers? And are we getting down to the nitty-gritty, even if it's a sample case? So I've tried to frame my question differently, Mr. Chairman. I'll shut up now.
Alex, we're with you.
Okay, thank you. And I am going to bring Mish in, because this is exactly the work that the team's been doing around retention. And we have just commissioned a piece of work around that. So I will bring Mish in a minute. But I think, you know, your point is some of the intelligence that we've got around some of the roster in practice. And that is a key challenge. And of course, that happens in individual service areas, and it is part of why people leave, is that work-life balance. But Mish, do come in, because your team has just done a significant piece of work on this. So please come in.
Yeah, we have that. Thanks, Alex. And I'll try and be brief. Again, I also struggle with being brief. But what we have tried to do is to hone down and understand the evidence base for change. because we are, as I've mentioned, a small function that cover a number of organisations and about 30,000 staff as a whole. So for us to incentivise managers, senior managers, chief execs, etc., to make the changes, what they need to understand is the evidence base. So my team have done a project to understand the feedback from some of the harder hit turnover areas. And what we are going to do around leaver interviews, yes, it happens. Yes, the recording of it is ad hoc. And what we haven't done in the past is be able to take that individual who wants something different and match them up with something else. So my team, we've managed to recruit a small data team, will be supporting the development of a system that will allow us to monitor, collate, and then analyse the leaver data across the system. So this is where we'll therefore be able to give the evidence base for the changes. And yes, it might be around rota changes, it might be about communication about other opportunities. So your friend might have been able to go and work somewhere completely different, but was still using her skills but didn't have the same rostering. So we're trying, again, is one of the many the pillars, I suppose, those 10 points that we're trying to cover to solve a problem that is significant.
Chairman, I'm very content with that answer. But I can ask you a question. This will come back to scrutiny again and again, I take it, because this can't be a one-off as far as scrutiny is concerned. And my apologies to the ladies on the screen, because I'm sure they've got better things to do. But
in fairness, I think it'd be a question for committee once we get to the end of the item today. It would be my intention to put it on the forward work programme, but that's for committee to decide. But yes.
Okay, thank you, Chair.
Anne Edgeler, please.
Thank you very much, Chairman. Yeah, my question really is, you talk in your risk comment about nurses' strike. I wondered if you've got any contingency plans in place were this to happen. That's my first question. My second question, well, my comment really, a comment about the school engagement. I'm really pleased to see that's happening, you know, to build some sort of relationship within the schools. That's really good, so thank you for that. But the pilot schemes, I understand there's 4 or 5 schools taking place. Whereabouts in Staffordshire are those schools, please? And my third comment actually is about mental health. We all know it's a growing problem throughout Staffordshire. Of all ages, people are suffering with mental health. Do you feel you're getting enough support from the government or money-wise to help move this forward? Thank you.
With you, Mish or Alex.
If I perhaps cover the industrial action point first, and then Mish, do you want to cover the schools point, and then we can try and address the mental health point together. So thank you for the question around industrial action. It's really live at the moment, and just to make the committee aware that it isn't just nurses, it will be across the NHS. So we have all trade unions balloting their members at the moment, which will include the BMA, the British Medical Association, and a number of others, which includes the Royal College of Nursing, Unite, Unison, and GMB. So that this is a really live issue, and actually I briefed our exec team this morning on this very issue, because the ballots are happening currently, and if members do choose to take strike action, which they may well do, of course that falls within winter. So one of the things we've got to make sure that we do is plan for that very carefully through our business continuity plans, and our business continuity teams are very much cited on this, are alive to the issue, and actually we know that this is a very real risk. And of course, one of the things that we've got to ensure that we do is make sure that our patients are safe. And all organisations have said that they, won't compromise patient safety, so we can use agency staff to cover should we require that, which isn't the ideal thing, but also for us to work with our trade union colleagues around maintaining patient safety and making sure that that isn't compromised. Now, we don't know that industrial action will definitely be happening yet. We've not been notified that that is a given, and it may be that trade unions take action short of strike action, or that they will picket. So we are watching and waiting. and very alive to the issue and thinking about our contingency plans and the risk. So, Mish, over to schools, because this is something very close to your heart and the team's heart, isn't it, in terms of your engagement with schools?
It is. So the schools, Madeley High School, Co-op Academy Frieswood, which is in Newcastle under Lyme, Stoke Minster School, Christchurch, which I believe is in Tamworth, and there's another one. So, and excuse me, I'll send it through to Jeremy so he can share that. That's just still to be confirmed. So I need to make sure that they're 100% on board before I share the name. They are 5 pilot schools. But what we're doing with them this year is developing the resources and materials for us then to have a suite of resources that all schools will be able to access. Having been into several of the schools myself, it's really clear that the kids want to ask questions. They want interactive learning. They don't want to sit and read a load of stuff. And yes, videos are sometimes appropriate. But what we're trying to do with science teachers is to develop a process where, you know, so for example, last week there was a GCSE class that watched an operation, a video, and then the week after that they're going to be taking part in the virtual work experience in an acute setting. So where we can have resources that everyone can access, but what we're trying to do is, because we have got a lot, as I've mentioned before, health and care people that work with us, is to get people to volunteer, to be trained by us, but to go into schools or to do a they call it speak to a scientist. So, you know, speak to a midwife, speak to a nurse, speak to a healthcare assistant. So have the conversation on Zoom, and you could have a number of classes that could interact at the same time by submitting their questions in advance. So where we can try and pull together those resources, again, they like the interaction. So we've had some investment to develop some actually equipment packs so that we can go out to schools and help them, A, with the healthy eating message, B, with the different types of education and careers they have available, and C, try and pull them in then to our virtual and then physical work experience, volunteering, apprenticeships, and then hopefully into our registered roles, depending on what they want to do. So yes, it's going to be an ongoing piece of work over a number of years, but we're working really closely with those 5 schools because we acknowledge that we won't get it right the first time. We want to develop something with their feedback.
Thank you for that, Mish. And your final point, Councillor Edger, just on mental health support, and I'm presuming you mean for staff in this context. So I'll just talk a little bit about that, and that's where we've had additional funding from the Centre for our psychological wellbeing hubs at system level. So all organisations have their own internal support mechanisms, which is a multitude of things around, as I've talked before, around occupational health, but also most have additional support for mental health needs of their staff, and that incorporates a number of elements. But the Psychological Wellbeing Hub has been a great success at system level and allows all staff to access that support, whether it be signposting, whether it be counselling support. There's a number of things on offer through that route, and that has been very, very welcome by our staff. But I have to say the mental health incidents of mental health issues for staff is on the increase. So I think I talked before, you know, it's our second highest reason for sickness and absence is stress, anxiety and depression in our workforce. So it is a very real issue for our staff, and we need to continue to focus on it. Thank you.
Thanks, Alex. Just wanting to wrap up this session, please. I don't want to talk any further about strike ballots, for example, because it's a national issue and we should leave that for the national politicians. But is there anything you want to briefly come back on, Councillor Edger? No. Okay, fine. Thank you. There is just one question I would like to ask. It feels like I got left to the end today. Career paths between health and social care. If we don't look at improving both the recognition and the professional qualifications that we offer at the bottom at the start of someone's career, then I think we miss a trick in trying to entice as many people into health and care. And second of all, demonstrating that it's a viable and valuable and an exciting career path for many people. I was up at Stafford University a couple of months ago, been a couple of times in fairness. They have some fantastic technology. And if we only look at health and care as menial work, then we won't encourage the people that we need to be encouraging to this profession. What are you doing on that in that respect as a joined up approach?
Yeah, thank you very much. And I know you've got a presentation in a minute from Andrew, I think, who's coming to present on the care workforce plan. But this is one of the areas we've been focused heavily on, particularly around entry-level posts, and Mish has already articulated that sort of work experience across health and care, and really thinking about those roles. But this is one of the areas that we've just received the apprenticeship award for in terms of our rotational apprenticeship and the career path. And I will not steal Mish's thunder because this is something that the team have developed across all partners to ensure that we do exactly that, that we give an overview of the broader careers in health and care, and actually that we start to work jointly together. And Mish has got some great examples of where health and care are joining together to provide opportunities for staff collectively together so that they're not working one or the other but across. But I will let Mish come in and comment.
Thank you. There's a number of different opportunities. So the apprenticeship pathway, each individual will have a placement both in healthcare, primary care, mental health, adult health, and they have a real opportunity to work with and embed themselves within all of those sectors, so that when they then decide to take a substantive job, they really do know where the best places to work for them, and also they're adding value in each of those placements. We've got our care reserve, so we recruit specifically for care organisations, not from other care organisations. So we're not robbing Peter to pay Paul. We're actually developing a new workforce. We're training them using our NHS resources to be deployed into care. But Jeremy, I do take your point, and I think what we're trying to do is incrementally increasing the opportunities available for the population to work in both health and care. This is something that's going to take some time for us. I think we're developing different opportunities. We have trainee nursing associates. So again, in care homes, we have people that can train from a healthcare support worker to become a nurse, and that's been invested in by Health Education England, supported by us, and working directly with care homes. So those are great examples, but they're not going to create the step change that we need in a short time scale. So what we need to try and do is to continue to work with Andrew, and we do work really closely with Andrew, to see where we can add value, where we can have an impact, then use those examples to try and change the mindset of our population to show that there are different and exciting opportunities available. Absolutely agree about the way that the public may perceive that the career in care. You know, it's not necessarily the most glamorous, unlike, for example, paramedics or firemen. It's that they don't have that appeal. So we need to work really closely with our colleagues to develop opportunities, but also change the public perception of that role via our media, our publications. And I think that's going to take time, because I have to be honest, there's quite a lot working against us in this space in terms of the kind of things that people are seeing in the news and COVID. So yes, we're working together, and again, we are acknowledged nationally and at the Midlands region as being an exemplar in this space, because we do work so closely both with the county and the city council, but also with Skills for Care and developing and kind of advertising our roles. But we do have a lot more to do.
Thank you. Really welcome that answer, particularly the point about the step change that's required, because I think if we carry on doing the knitting, we'll get the same outcomes, and we need to, I'm not suggesting you're doing knitting, by the way, but if we carry on doing the same old, we're going to get very similar results, and I think we do need to make that step forward. So I think with that, that brings an end to this morning's agenda item in terms of health, careers and people. So Alex, Mish, can I thank you for your involvement this morning and the presentations and the packs before. I think the appetite from committee is demonstrated by the length of time we spent discussing that this morning. I think we probably do need to get into a level of detail that we probably haven't got and focus a bit more in specific areas. So, for example, I recognise we haven't seen the action plans that go underneath this. Just let me make a couple of other points, if I may first of all, though. First of all, congratulations on this regional award in terms of national apprenticeships. I'm sure you're very pleased with that, and good luck in the nationals, obviously, when you come to that in a couple of weeks' time. Second of all, something that was in front of committee's mind 3 years ago when you came last time, maybe 4, was the point about not having redundancies in one part of the health system for then the person to pop up in another part of the health system the next day. And I recognise that you've made a saving of 4 million quid and put an end to that. So it should never have happened in the first place, but at least it's resolved itself. Maybe next time you could bring your non-exec director who's linked to people, because I think that would demonstrate that actually the system is very, very keen to talk with one voice from health and care, and there is a real valuable role in place. I think today we've sort of challenged you on a sense of pace, some of those action plans that go underneath it, but also some of the detail in some of those areas like flexible retirement, because we recognise there isn't a silver bullet out there, and it's a range of, it's a multiple of different activities that you need to do, and I think that's what committee would like to dig into next time. As I said on the introduction, this is what I saw as a sort of an entry into understanding some of your very difficult world, and appreciate the time that you put into it, and the challenges that you have. I think committee is very supportive of the work that you're doing, because we all need to see people, because we'll all eventually need somebody to help look after us when that time comes. So thank you for your involvement this morning, and I'm going to move on with permission to the social care side of workforce, and you're welcome to stay or go as the case may be. But otherwise, I'm going to welcome Richard. Nice to see. Sorry. Let me welcome the Cabinet member, first of all, Julia Jessel. Let me welcome Richard Harling and Richard's team, who I am reliably informed is Amy Duffy and Pete Wood. So can we restrict comments, opening comments, to 5 minutes, whoever's leading off on that, and then we'll move into questions. Julia, with you.
I will just do a very brief overview and then hand over to Richard and his colleagues. Very interesting debate you've had with the NHS colleagues, and I think it demonstrates that we both have similar challenges of an ever-increasing demand and a smaller available workforce. If you look at the unemployment levels in Staffordshire, they are still very low. And I think it highlights the fact that whilst both organisations are looking and improving their recruitment processes, which is absolutely right, when you're in a very competitive market, you have to make sure that your recruitment process is attractive at the front door, it's easy to access, but actually you contact people and you process the whole system as quickly as possible. But the key thing is retention. Recruitment itself is an expensive process. It's a very challenging market out there, so it becomes even more important that you retain your staff. A certain amount of, it's known as churn, is a healthy, but beyond a certain amount it's very disruptive. So I think it is important, and the update does identify areas through well-being and support in that direction, that actually we are trying to ensure that we retain as many of the staff as possible. And I think one of the things you highlighted, Chairman, at the beginning of the previous item was thanking those people who work in social care for all their efforts, for their commitment to the people that they look after. One of the messages that comes back from social care staff is because of COVID, and during COVID, the NHS was put on a bit of a pedestal. It was put on a huge pedestal, and people working in social care felt that their work wasn't being appreciated. And there's got to be a lot of work done to actually change that, to change the status of social care work. And that's why I call the health, the NHS part, and the social care part, the caring industry. We need to look at it as a coherent industry. If social care doesn't work, our hospitals clog up and they can't work. So I think it is important that we look at it and work together as we're doing to have that coherence, that we're not doing things which are in competition with each other. I think the other thing with the NHS is, of course, most of their employees are their employees, directly employed, almost 100%. Within social care, of the 21,000 people working in that industry, the vast majority of them are working for private independent contractors. They are also far more dispersed. They're working in home care, they're working in care homes, and that in itself adds an additional complexity. I think the other thing I would say is that apart from what is in this briefing paper, and obviously Amy, I was going to say Andrew's not here and Richard, will be able to give you more detail, and I don't want to steal their thunder, but I wanted to highlight that as a social care service, we're looking at the wider agenda. We have an increasing demand, and I keep saying to people, there isn't a never-ending supply of employees. So there's the social, there's the financial resources and the human resources that have limitations. Therefore, we've got to make sure that we make best use of those resources. And it's by introducing assistive technology, which we're doing in care homes. We've got a bid in to introduce IT systems so that care homes can transfer to digital records. Quite a lot of them are still working on paper-based records. So we're looking at that wider picture. We've got home care providers. We've encouraged them last winter to exchange care packages so they're not driving across the county, crisscrossing and being inefficient. People who work in the care industry don't actually want to spend most of their time in a car. Also driving the green agenda, the least mileage they do, the better. So that's an overview of what we're trying to achieve. I'm sure you'll have more detailed questions, but conscious of time, Chairman, I'll hand over. Thank you.
Thank you. Is there anyone else, Richard or Amy, want to, or Pete?
I don't think I've got very much to add to that, Chair. I think if we get into questions, and obviously there's some detail in paragraph 12 about what else we're planning. If the committee have got any other ideas, we'd be very happy to hear them.
Thank you, Richard. And yes, I thought it was a very useful and clear and concise report, which left me very clear in terms of what the challenges are. So appreciate the writing and the detail within that report. Charlotte, I believe you want to come in.
I note that there's a turnover of something like 28%, but 64% of those leavers stay within the sector. So when those leavers go out of a particular provider, is the issue they have with their own employer, or is it an issue of career progression? The paper says that a third of the workforce has more than 10 years experience. So what is being done to ensure that there is career progression for them so that they actually stay in the sector and progress in the sector? Secondly, I'd be interested if you could say something about the Social Work Learning Academy and also the Council's new applicant tracking system, and how is that helping with both recruitment and retention? Thank you.
Feels like it's going to be a game of tennis between Richard and Amy, so where are we going first?
I don't know, Amy, if you could start by the people leaving and whether they go to other employers or a bit because they're looking for career advancement or because they're, I guess, fed up with their existing employer. And then perhaps I'll do Social Worker Academy and applicant tracking system.
Thank you. Just to update you, since the report was published, we now have the 2021-22 figures. And just to note that the leavers remaining in the sector has now decreased from 64% to 59%, as according to Skills for Care. When we look at some of the local intelligence and the soft data, we do see a number of people moving between home care providers. The reasons for people staying within the sector and moving between providers is quoted as A, rates of pay, be, the supporting expenses and so forth. We don't often see career progression quoted as one of the main reasons for moving in between providers. That is only local soft intelligence though at this moment in time.
In terms of the Social Work Learning Academy, that's actually hosted for us by MPFT, Midlands Partnership Foundation Trust. It supports both recruitment and retention, but also continuing professional development. It tends to focus on the cadre of professional social workers and social care assistants who work either for MPFT or the council. It does get very positive feedback from staff about the way it supports them to continue their role, and it is one factor they cite sometimes in being either attracted or staying with either of those organisations. So we do regard that very positively, actually. The applicant tracking system, that's essentially a system whereby if the council or MPFT are recruiting, you kind of sign up for it initially, even before you submit your CV or application form, and it then kind of sends you reminders to say, you know, have you thought about applying, and it supports you through the process rather than leaving you cold. So the idea is it sort of sucks people and draws people in.
To come back and find out if we're doing anything to promote career progression, given that a third of the workforce have been in social care for over 10 years. It seems to me that if you're in the social care workforce for over 10 years, you would expect some sort of career progression. Appreciate they may be with many different private or voluntary sector providers. But it seems to me that one of the issues around the perception of the social care sector is that it's sort of a dead-end job. And obviously, if there is an opportunity for career progression, then we're more likely to keep people within the sector.
So I think that's something we're thinking about very actively at the moment, and we are working very closely with NHS colleagues. One of the potential opportunities is to think about job roles which could span apprenticeship, social care, go into the NHS, perhaps into council employment, back out again to the independent sector. There are all sorts of potential risks with that, but there are all sorts of potential attractions and opportunities as well. So I don't think it's a nut we've quite cracked yet, but I think we are exploring a range of possible options. I don't know, Amy, whether you've got any more detail about work that's ongoing.
Thank you. So once again, looking at the local soft intelligence that we received, one of the biggest pieces of feedback from our social care workforce was the understanding of career opportunity and progression. So what we are doing as part of the programme in a partnership with Mish and Co will be to look at those career pathways and actually do some exemplary pathways. So if I start life as a home care worker, what are my opportunities for progression, and where would I need to go in order to find those opportunities and the funding to support that? So it is something that the workforce are asking from us and something that we are seeking to develop in partnership with them about what are the opportunities and what training do I need to get to my final goal in terms of my career.
Do you want to come back further on that? So, sorry, Julia.
Can I just add, one of the opportunities that I think we have is, of course, the NHS. Often people, when they've done sufficient years to get their pension, they may be 53, 55, retire, or actually some of them retire prior to then, depending on their terms and conditions, is when you go around care homes, you'll find that there are a fair number of staff that have worked as nurses in the NHS, but actually want a more flexible job, flexible terms and conditions, but also they want to continue to work in the caring industry, but in an industry where they can build up personal relationships with the people that they care for. And that's one of the things that I think is a big selling point for social care, is that actually often you're looking after people for can be a number of years. And the staff find that a very satisfying, rewarding experience. The NHS, by its very nature, there is a faster turnover of people and you're never able to really build up those relationships. And I think that is something that if staff from the NHS do retire, that actually we use the opportunity to say, well, you can still be in the caring industry, come and join us. So I think there's a whole set of opportunities across the whole of people's working lifespan.
Can I just sort of probe a bit further on this, because it's not as if the social care sector has appeared overnight, and I welcome the comments you've made in terms of developing that career progression, but I guess I would like to feel that there was some passion and some pace, which was a comment one of my colleagues made earlier, in terms of delivering against that, and so that's my first point. So when are we likely to see some tangible outcomes? Because I'm trying to do the maths, and I will do the maths before the end of this session. But there's a phenomenal number of people who are leaving who are not staying in the sector. And actually, if part of that is that we don't have an appropriate career path, then I think we're missing a trick. We're making the job harder before we even start. For an example of that, I note under qualifications and skills, paragraph 7 on page 76, actually, we've got nearly half of the workers within social care with a recognised qualification. How many people choose to make this a career path because they see it as a profession rather than a vocation?
That's why I highlighted that we are very different from the NHS, because they are the employers of all their staff. We are not the employers of a majority of the people within the care sector. And whilst we can put things in place, we can put career paths in place, a lot of it is down to working with those employers. So that's why I highlighted at the beginning that there is that crucial difference. And it does make it a bit more of a challenge. So I will remind members that that is the case.
Just let me come back then. It's a very good challenge back, but I think the point is about framework. If we don't create a framework, I mean, you use the words working with employers, absolutely agree with that, but if we don't have a framework, and that might help drive the quality of our care homes as well, which is something that we've talked about a number of times over the years. And I would just like to see there was some commitment to this and some drive forward to it. Because actually, we're all going to need, well, the majority of us are going to need social care, and frankly, I want it to be the best possible in Staffordshire, as does everyone else in this room. Amy, did you want to come in? I'm not debating the cabinet member. I do apologise. Amy.
Thank you. So just in terms of the tangible actions taken, so we do have ongoing critical support from both our care market development team, our quality assurance and our provider improvement response team, who work tirelessly day to day on the ground to support with that development. In terms of some of the more recent actions that we've achieved, the extension of our VivUp lifestyle portal to our adult social care marketplace. Staff told us that acknowledgement, recognition and thanks is critical to them, so we have been able to extend that free of cost. In terms of our involvement, we have brought together, or we are bringing together rather, a strategy which will result in, from an adult workforce perspective, 8 key themes. The strategy we anticipate will be live in January or February, but the actions that we are working upon, for example, building career pathways, exploring social care academy, the training and development offer for nurses, managers, that work is happening in tandem alongside bringing together the strategy. And I think the key success of our strategy will be that we do actually have our independent marketplace informing, working and delivering on that strategy with us. So we have got their buy-in to work in partnership with them. Thank you.
Brilliant. I know you talk about the strategy coming forward, be live in January and February. I'm assuming you don't mind us diarising that for a future meeting at some stage, just to input to. And second of all, what better way of saying to staff that we value them, even though they're not our direct staff, than having this sort of investment that is going on. Sorry, I'll give way. Jill.
I can't leave this room without saying this. Absolutely agree with Councillor Jessel.
And I'm beginning to feel, Chairman, that maybe there's a personal interest here about your later life care agenda.
Thank you.
I just want to state the absolute obvious, that is that we're here scrutinising today, and we are actually the people who are on the rock face, we're on the coal face with our residents. We're meeting carers in their homes who are coming along to see our residents. We're hearing the absolute truth. They're not coming before a panel or an interview. They're talking heart to heart. They don't know who we are. We've popped in to see a resident. They have no idea who we are. And you know, what better than us to give that informed opinion? Professionals, yes, absolutely. Couldn't agree more. They have an opinion. But, you know, I think we've got an absolutely invaluable role in feeding forward what we see from social workers, from care workers, and visiting our residents in hospitals. Thank you, Chairman.
Thank you. Was there a question you wanted anyone to pick up? Apart from, I can confirm that I'm in perfect health for this moment.
The question's already been asked, that there has to be career progression, no matter what the status of the carer. There has to be. And I'm sure we're losing carers because they're extremely low pay. I'm talking home carers. But for them to have something at the end of their day to look forward to, retraining, you know, NVQs, all sorts, you know, even McDonald's, and I'm not belittling carers, the caring profession whatsoever. If we go into McDonald's for something, they've got a star or a row of stars. You know, it's great to give self-worth to our carers. That was my question. Thank you.
Thank you for the second part of your question and for your concern. I have now done the numbers. You know, 20,000 people, 28% turnover, 59% staying in the sector. That seems to me to be about 3,000 odd people who are leaving the sector within Staffordshire. That seemed to be my maths. Maybe I got that wrong. It did still seem to be a big number in terms of percentage-wise. It might not seem such, but when you aggregate it against the number of care workers. Can I ask a different question? And maybe you can just respond with any comments that you have to what Councillor Hood's mentioned. Have we done any work to identify why people aren't going into the sector in the first place? Please.
So that has been one of the key questions that we have asked locally in terms of pulling this strategy together, and it's also one of the questions that our care market development team focuses on when working with providers and trying to attract through the recruitment and retention work that we do. We did obviously see a change in our numbers during COVID-19, but obviously we are now seeing a reduction and more people leaving the sector, unfortunately, as the wider economy opens up and people return to other roles that were no longer available to them during furlough and so forth. So the initial feedback we have about people joining the sector is not everybody appears to see the possible career pathway and progression that is available to them. There are comments about the professionalisation of the career, that we shouldn't just be talking about somebody just being a carer. It is about passion, it is about vocation, and it is about critically making a difference to someone's life. When we look at the local engagement that we got, you know, we had 67% of our respondents say to us they remain in this job because of the satisfaction that it gives to them. And there are comments and questions about pay and benefits that may be preventing people from joining the sector.
Thank you. Just in terms of the pay and benefits, can I just focus in on the benefits? There are a number of benefits that Alex and Mish talked about this morning, not least things like, you know, discounts for NHS workers. Do those discounts apply to everyone in care? And are we trying to sort of aggregate across the 30,000 people that are employed in health and care across Staffordshire?
Thank you. So one of the biggest themes during this piece of work that we have found out is that not everybody is aware of the opportunities and resources available to them. That includes social care workers being able to access the blue light card, which is open to our NHS workers, which offers them a range of discounts. We have also, through partnership with colleagues, the Health and Wellbeing Hub that was referred to, that is available to health and social care. We have also extended our Staffordshire County Council offers, as I noted, Viv Up, but we also have opportunities such as Think Well and so forth that we have extended to the marketplace. One of the work streams will focus upon where we see a number of even local businesses offering NHS discount. We would like to do some work in terms of making those discounts eligible for both health and social care staff members. Thank you.
Thank you. I'm not seeing any, I am seeing an indication. Just let me come back on what you said. I think that's really valuable. I think what you're saying is it makes health and social care an attractive career. So maybe come back to us with some thoughts in terms of what role this committee can play in terms of publicising that further. Let me bring in Rosie Claymore, please.
Thank you, Chair. I'm looking at item 12. And things going forward. The last sentence in there, we're also reviewing whether there is any potential to support non-drivers into the home care market. Could you elaborate on that for me, please?
So in terms of our local intelligence, what we have, what our local home care providers have told us is that obviously the desirable would be to employ a person that is able to drive. What we are trying to understand is how can we support with those transport options. So we are exploring a range of options which include looking at the employment or persons who are able to drive volunteering in some capacity to support our care workers. We're considering proposals such as e-bikes, and we're also looking at is there ways that we can support the workforce with learning to drive, noting that the expense that this is in the current cost of living crisis.
Rosie?
Yeah, thank you. I do find that quite interesting because quite a few of my members of family are in the care industry. And there does seem to be, from what I'm being told, a big stumbling block with recruiting staff because they can't drive. And the cost of learning to drive is very expensive. I'm not sure about e-bikes, how that would work in the bad weather. But yes, certainly help with learning to drive would be a step forward, I think. Thank you.
Thank you. A really useful intervention. I was in Berlin a couple of weeks ago and I saw everyone on scooters. I can only think that if I was on a scooter, I would end up in A&E, so needing professional support. On that basis, just let me bring to a conclusion this morning's session on this. I think we probably all recognise the importance due to the staff turnover and the valuable role that you, Councillor Jessel, indicated all staff within social care do on a day-in, day-out basis and often is forgotten. But it's a really important profession. I think your points about a care industry are well made. We would like to bring this back again in line with the health side of it, and maybe one day we'll persuade you to join up the conversation so that it is one presentation on health and care, because it would demonstrate we've made a step forward. But appreciate the work that you, Richard and Amy and Pete and the team are doing in this respect. So thank you for that, and we note, I think, the report. Okay, thank you. Stay, go, not members, sorry. We'll move on to item number 6 on the agenda, which is with you, Heather, relating to the Ockenden review, please. Maybe you might just pick up Richard Cox's question, which related to staffing with within maternity services at some stage as well during your opening comments. Please. And welcome, Alison, as well.
Thank you. I was going to say, can we also welcome Alison. What we're going to do, I'm just going to do a very brief introduction. Ali's going to give a very quick run through of the paper that you have in front of you, and then we're happy to just take any questions. So I think I was with you a fortnight ago and we briefly touched on maternity at that meeting. And I think prior to that, the last visit, I'd already agreed to come back today and present a report on Ockenden, on our response to Ockenden, and that's what you have within the pack that you have in front of you. So Ali's going to briefly summarise, as I said before, the key points. But as you know, and I'm sure everybody around the table will be fully briefed on the fact that this is not the first report we've received into maternity services and issues regarding maternity services. And even this week, there's going to be a further significant publication with the report being published into an investigation of maternity services at East Kent hospitals. So I just wanted to really reassure you all that as we receive these reports, and even when we don't receive these reports, and that would be our preference, because we would rather these things weren't happening, we do work constantly to ensure that the learning from all of these is translated into practice and into a visible and palpable service improvement. Ali's going to pick up on the maternity staffing levels, but just to say really with regard to staffing levels do feature as a key theme in the Ockenden report, and I'm sure Ali will have it as one of their headlines. And it really does mean and reinforce the need for us to make sure that we utilise maternity workforce in the areas where there is the most risk and the most demand. There's a bit more information I could probably give you, but it might be easier if I just shut up for a second and let Ali do the headlines and then perhaps pick up any questions.
Thanks, Heather. Good morning, everyone. My name's Ali Budd. I'm the lead midwife in Stafford and Stowe Contract Local Maternity and Neonatal System, and I think I've met the majority of you before under similar circumstances. So you've had a really short paper, and it really is a brief overview of a very in-depth, detailed Ockenden report, which was published in March 2022 this year. It was part 2 of a previous very detailed report that was published in December 2020. So what I've tried to do is just to give you just a brief overview to help you understand what is included in the report. So section 2 describes what the mandated asks have been following the publication. So it's important to note that the first publication in 2020 had 15 immediate and essential actions that were must be dones. The report this year had 7 immediate and essential actions with subcategories. They weren't mandated to complete. There was a letter which is detailed in section 2 that gave us the mandated asks, but there was a call to benchmark the services against those 7 immediate actions, although not a mandated implementation of the actions. So what section 3 does is it gives you a current position of all our providers, our 2 main providers, in relation to providing assurance and compliance against those immediate and essential actions, the first 15 that were out in 2020. So it provides you with a position, and then what the final section does is just gives you a bit of an overview of the immense amount of work that's been undertaken to review and understand and implement those actions, but then also some of the areas where we've still got some concerns, where you know it's a little bit harder to implement. There's some more complexity around implementing them. So that gives that in section 5. And you know, following on from the conversation this morning around workforce, you know, the main issues really around maternity are around the workforce and connecting to the workforce. So that's the paper. I'm happy to take questions in relation to specifically to Ockenden, but I have got a little bit of an overview I can give on the staffing if you want. I can do it in whichever order you'd like to.
Happy to have that now if you want, Alison.
Okay, yeah. So I have got numbers and without going into the depth of numbers, because numbers really are headlines. When I was at last committee with you, we did touch on the variation between what we thought might be interesting was to look at the staffing numbers before the pandemic compared to the here and now. And I have done that, and I've got the numbers. I will send them through. I've got a couple of slides that I can send you. But I think just to give you the headlines there. Both providers are reporting, in terms of numbers, a similar vacancy rate to that they had before the pandemic. So they're both reporting, now that they've had their newly qualified midwives start in the last month or so, they're both reporting kind of 10 to 15 vacancies out of their whole-time equivalent budgeted establishment. The difference is that during the last 2.5 years of the pandemic, we've had that context of the pandemic that we've been working in, and you know, we've had a lot of detailed discussion about what that's meant to all of our health and social care workforce. But within that context, we've also had our Ockenden reports that have been published. And we know that what that's done is that's created a spotlight on maternity services. Now, the benefit of that is that there's been a significant review of staffing. And again, our two main providers have, as a result of that, have had their staffing reviewed, and they've had significant investments into their budgeted establishment. So the vacancies that we're reporting now are against new budgeted establishments that have been uplifted and increased. So that's a positive thing, because that spotlight has meant that we now know we need our staffing improving. What we're now in a position for is embedding them. So we've got a lot of newly qualified midwives. We've got a whole raft of recommendations around staff training that have been born out of Ockenden that are adding to that pressure, because that's more training than we would normally be doing. And the work now is about embedding those improvements to get the workforce into the best place that they can be, to be the skilled workforce that we require. So what I can do is I'll send you the numbers through that just give you those headlines, but that picture is within a context of significant investment, which is extremely positive for our maternity and neonatal services. We mustn't forget our neonatal services. So I'm happy to take questions.
Thank you, Alison. Thank you, Heather. I'm looking around the room, and I'm going to ask the first question. So on that basis, has Ockenden scared people off from making a decision that maternity is a career path?
I might defer to Alison on that one, given that she's currently, I used to be a midwife, I'm still a trained midwife, but I'm no longer registered. But Ali very definitely is a registered midwife, so she may be better placed to offer a judgment on that one.
Yeah, feedback from our staff, from a leadership perspective, our senior midwives in our leadership roles and our clinical midwives, it is definitely harder to practice as a midwife than it ever used to be, and that's primarily because of the scrutiny that comes with that and that added pressure. And we are definitely seeing our I say younger midwives because I'm old and I can say that, but our more newly qualified midwives are finding it increasingly more challenging it's hard enough to qualify as a midwife without having this additional pressure. So they are finding, and we do get feedback that there are more leaving in the first few years after qualifying. And at the other end of the spectrum, as we've discussed this already today, you know, those midwives that are of an age where they can take retirement at 55 are in a position where they are considering that, and some are taking that up. That said, we are doing a lot of flexible retirements. I'm one of them. And there are a number of senior midwives, particularly, well, lots of clinical midwives too, that are doing the flexible return work, and they're coming back on, you know, they're still staying in the maternity service because they've got that experience that we want to encourage to keep. So I suppose the short answer is yes, it's a lot harder.
Thank you for that. Is there opportunities through use of technology, like sort of immersive technology and not virtual birthing wards, but these sort of, you know, the birthing wards like Stafford University have got, for example, which can really actually give people a taster of what the profession is about, to try and remove some of the barriers to people wanting to join that career, because it's a very fulfilling career, I'm sure. There's nothing better than seeing the first breaths of life coming into the world.
Yeah, our services use those simulators for a number of things. They train the student midwives using them, but we also do our kind of multidisciplinary training using simulators as well, you know, for obstetric emergencies, those sorts of things. So they are quite useful. I don't think we've looked at using them in terms of by way of attracting people into the profession, but that is something we could perhaps look at. But they're certainly used extensively for training purposes.
Perfect, thank you. Welcome that. Anne Edgeler.
Thank you very much, Chairman. Thank you for your report. Yeah, I just want to make a comment, actually. I think we've learnt an awful lot from this Ockenden report, and I'm really pleased about that, and I can only speak how things are happening at the moment. I've got one member of my family that's 7 months pregnant, and I cannot fault the service that she's been given. It's absolutely first class. I can't complain at all. So thank you for that. And you know, I'm just really pleased. You know, having been involved in the last 10 years where one baby, a very dear friend, baby was born dead, and then another one where I was involved with, where another lady, she was 25 years old, gave birth, but complications at birth, and it ended up with she had a colostomy. Had to have a colostomy at 25, and it cost the NHS actually about £500,000 in payment. So I'm really pleased that, you know, things have moved forward, and really pleased that things have improved. Thank you.
I didn't note a specific question apart from your appreciation. Yeah.
Sorry, I just wanted to make a comment how things have vastly improved, and I'm really pleased from a personal point of view how things have moved forward.
Okay, that's what I thought I had. So thank you for that, and I'm sure Alison and Heather both welcome that. Just let me go on to one other area, given no one else is indicating. Sorry, it seems to be the JP show today. The question I got for you was, do we have any definitive dates on Samuel J and Stafford in terms of the freestanding birthing maternity units, by any chance, please?
Thank you. Shall I respond? I think just to say, first of all, we came prepared to talk about Ockenden, so we've not brought the most recent updates. But the short answer to that question at the moment is no. And it's no, not because we're not working on it and not because we're not working to try and resolve the situation. It's no, because of all the issues we've outlined in terms of the need to meet the requirements of patient safety, ultimately, maternity safety, and to recognise the recommendations of the Ockenden review.
Thank you, Heather. I mean, I think what you're talking about is a risk-based assessment, and I think that every mother, well, every parent, in fairness, would prefer you to do that. But I will keep continuing to nag you so that a temporary doesn't become a permanent, and that we do get it reopened at some stage, and preferably sooner rather than later. But understand the comments you've made. Okay, I'm not seeing any further indications from anyone else on this. I know you've been with us a couple of times over the last, probably 3 times in the last 12 months. I think it recognises the importance that we saw to Ockenden and making sure that we'd scrutinised services as effectively as we can without being professionals in this area in terms of for our residents. So Heather, Ali, thank you for your input this morning. We may well bring you back at some stage just to sort of sense check Ockenden, but you know, you've probably got a breather for a fair few months now, so we look forward to seeing you probably in the new year. So I'll wish you a happy Christmas, and we will move on to the next item on the agenda. You're welcome to stay or go, as the case may be.
Thank you. Thanks.
Thank you. Okay, so that brings me on to item number 7, which is a follow-up in terms of our discussion on the George Bryan Centre. And I'm assuming that, Helen, that you're going to lead off on this?
I am, certainly. I am joined today, sorry, I'll introduce myself. I'm Helen Slater, Head of Transformation across Staffordshire and Stoke-on-Trent ICB. I'm joined by Nikki, who will introduce herself now.
Hi, I'm Nikki Bromage, Head of Strategic Commissioning for the Staffordshire and Stoke-on-Trent ICB.
So in the paper that you have with you today is a summary of the queries and questions that you put to us on the 1st of August when we came and shared the business case that we developed, the draft business case for the future services for inpatient mental health services across South East Staffordshire. You were really helpful in terms of scrutinising that business case, and we have provided you with a series of response to the queries that you raised. I do have to make an apology. Within the paper, there is a standard operating procedure regarding the financial assistance for travel that is in draft from MPFT. That should have been attached to your paperwork, and we will get that circulated. But I can summarise in terms of that standard operating procedure that is looking at supplementing the digital support and the flexibility in terms of visiting arrangements with a proposal around assisted travel support for relatives. But that's in draft. It's for further review with voluntary sector partners and other stakeholders, but we will get that circulated to you. And we will bring that as part of the update that we're intending to bring to you next month.
Thank you, Helen. Welcome that. And yes, we would like to see that, please. Committee, I'm going to propose we take this page by page, because otherwise we'll dot across this. There are specific answers to the questions that we as committee asked back in, I want to say, August. Feels a long time ago. I'm currently with committee on page 81, which is just the outline in the background. 82 details the questions we specifically asked. So that takes me on to 83, which is the first response, which relates to raising about communication and raising awareness of the community mental health offer. Has anyone got any questions on that? I'm going to very quickly move on to 84, so don't delay in raising your questions. So 84 is talk about the key performance indicators. I've certainly got a question on the response on 84. I'd expected to see some numbers rather than an explanation of what the numbers would mean if I had them. So it might just be useful just to have some of the numbers. I know your point is that the ICB has got the numbers, but actually we still have a responsibility to scrutinise the numbers. So I'm not really bothered the fact they're elsewhere in the system. I would have liked to have seen them, just so that we can put some assurance around the various models being talked about and proposed. Sorry, Nicola, we're with you.
Yes, thank you. So we absolutely recognise this, and we'll be working to make sure that these are routinely provided as part of the ICB updates that come to you as a matter of routine. So they'll be included in those moving forward, Chair.
Probably me rather than you. So actually, apparently we're on page 90, apparently. But you're clever enough to get there before I am anyway, so. Okay. Any other questions on page 90? Apologies, members. And if you need to go back a page, then please feel free. No? Okay. So I think that takes me on to, this is going to be very dynamic, page 91, which is user satisfaction ratings. Okay, evidence of, that takes me on to the next piece on 91, which relates to transport and support provided for relatives, which I think is what Helen described earlier. Rosie Claymore.
Thank you, Chair. Yeah, and thank you for your responses. My first question was going to be, where is the SOP? So you've answered that for me, it's not there. I'd be very interested to see that. As you know, this is the main issue that residents in Tamworth have great concerns about. I do realise that there are some digital offers available, but again, the view from myself and the wider community in Tamworth is that this will not substitute for face-to-face visits from friends and family. So if you could just give us some information about what's on that standard operating procedure at the moment, that would be helpful. Thank you.
Who's picking that one up?
Do you want me
Thanks,
to
Helen.
take that one? So just in terms of the standard operating procedures, so as with any relatives that are supporting their loved ones that are admitted into St George's, the conversation is with the clinical team in terms of what the best way to facilitate visiting. And so there is offers in terms of flexible visiting. There is also a proposal that the travel assistant, the travel would be supported, the travel costs would be supported of those relatives that are travelling across. There is a cost in a travel per mile cost in there, and is subject to let me just get the right terminology for you. Sorry, apologies. In terms of the visitors that live within the South East Staffordshire area, and those visitors in receipt of a benefit or other financial support from the government, a self-declaration will be required. They would be need to make a claim through the ward manager and have evidence of expenses incurred. We do recognise that travelling can either be through car, public transport or train in terms of access to St George's, so that would be taken into consideration. But apologies, we will get that circulated to you. So we are looking at that reimbursement of the cost that any family member may incur.
Rosie, do you want to come back?
Yes, well, thank you for summarising that, and like I said, I'd be very interested to see when that arrives in my inbox. However, to me, it still seems there's an awful lot of obstacles to go over for visitors of people with mental illness that are probably suffering from other possible stresses in family life. Yeah, it just seems like a lot of obstacles to go through for me.
Can I suggest we look at what comes back in terms of from Helen and then have a discussion from there?
Have we got a time scale for when that will come back?
I'm guessing Helen will circulate at some stage this week for us.
I will send it over this afternoon to Deborah.
Thank you, and then we'll circulate from there. Yes, absolutely. Okay, I think that takes us neatly on to page 92. And this details with 93 the vacancies across the Mental Health Trust. That takes me on to page 94, which I think talks, finishes that conversation and then talks a bit about the commitment to long-term community mental health services locally. Helen, just a point from me. I'm at the top of the following page, which is 95. It says MPFT and the ICB are committed to ongoing investment in voluntary sector services, which work in conjunction with the clinical service model. You know, that's a very open-ended sort of commitment, which feels very less defined than I would have liked it. If you'd have said something like there is no attempt to row back from delivering services in the community, you know, I think that would have been a stronger statement. I just wonder whether there was a stronger statement you might want to say and just to support that commitment to community mental health services. Nikki, we're with you.
Yes, absolutely. We can strengthen that statement because there is an absolute commitment to ring fence that money for community mental health services. So yes, Chair, we'll strengthen that statement for you.
Thank you. That's really helpful, Nikki. And apologies if I call you Nicola earlier. It's Richard Cox.
Thanks, Chairman. It's just a follow-on question from that, because funny enough, that's exactly where I was wanting to go. In terms of the voluntary sector, is there a danger that you're heavily relying on them to offer the services in helping those people with mental health? And is there somewhere within then a loophole or a cavern of where things aren't being covered in the right direction? Because it's about signposting, in my mind, that you're sending somebody to the right voluntary sector to assist, and not then being passed on to somebody else, and then that person in themselves has said, I've had enough, nobody knows what nobody cares, everything else. And I really wanted to drill that down, if I may.
Nikki.
Yes, thank you for that question, and apologies if it hasn't been articulated in the way that we would hope. It's why it's really helpful to have these discussions, actually. So when we talk about the voluntary sector within the community mental health transformation, they are formally commissioned by us, so they are part of our service provision and pathway. So it isn't a case of signposting to, and I absolutely take your point on that, that I think, in previous years there has been a sense of that. So they're an integral part of our service delivery. So care is sort of wrapped around individuals, and people can be stepped up in terms of the pathway or stepped down as appropriate according to their need. But they are very much a funded provision as part of our community mental health offer, and will continue to do so. In relation to your comment about being dependent on the voluntary community sector, they are absolutely a key resource and an incredibly valuable resource in terms of our offer of community mental health support. But it's really important that we have a range of options available to us, and obviously where clinical care is required, then clinical care will always be delivered, and that will be done in partnership with our social care offer. So we're really only using our voluntary sector commission partners where it's appropriate to do so, and to ensure that we can focus that specialist clinical time where it needs to be. But very much it is a partnership approach to delivery across the piece. Thank you.
Richard, anything further? That's fine. Okay, I'm still on page 95. And just moving on to, I don't think we need to talk about the transport policy because that's covered elsewhere. We've talked about, here's the answer in terms of community services being ring-fenced, and the figures across the next page, which is on page 96. That's fine. In terms of page 97, which has got the answer to the greater transport mapping, no one's indicating, so that's okay. Technology in terms of complementing human contact, I think that's more of a statement, isn't it? And that's 97. Page 98, safety. And then in terms of wider partner discussions, just let me ask a question under the wider partnership discussions or partner discussions. The final paragraph says MPFT is actively working towards bringing Cherry Orchard, nice name, back online as an adult mental health community venue. Can you maybe just talk a bit more about that? Because obviously subject to planning, but I don't recollect out of 608 pages, and I do apologise if I missed it in the 608. I don't remember having that as part of a conversation previously, and I would really be interested in terms of the overall services and service offer for the residents in that area, what that looks like and what that means and what the aspirations are, please.
Am I okay to take that question? So one of the recommendations that came out of the Clinical Senate was obviously to look at community mental health space in terms of estates, and Cherry Orchard is a large building that's located in the centre of Tamworth, very accessible to public transport. There are car parks in front of it, etc. So we have been so MPFT have been working towards realising that estate and making it available to base some of our community mental health provision from there. So ensuring that there is that centrality within Tamworth itself that's very easily accessible to families and their carers.
Sure.
So it will deliver a range of community mental health services from there. So we're still in discussions around MPFT about what what that space can offer in terms of clinical room space, etc., and how it might be utilised to deliver some of the offers that we have available.
I'm going to bring in Rosie Claymore, and then there may be a couple of other members who want to just come in on this. But first, Rosie.
Yes, thank you, Chair. And yes, I do welcome the fact that Cherry Orchard is being considered as a venue. I'd like to hear more about what sort of services it's going to provide. I mean, it was closed down some years ago. I don't know the reason why it was closed down, but we seem to be going down the route of reopening that. What services are we going to be looking at being provided from there? Thank you.
Nikki, with
So
you.
I can't give you a definitive list because obviously we're going through, MPFT are going through planning. So it's about what clinical space and how it's configured in terms of what could be delivered there. But certainly in terms of what could be delivered there, it would be, interventions in terms of psychological care interventions. It could be some of our improving access to psychological therapy services could be based there. It could be some of our carers groups could be based there in terms of delivery. So there's a range of options available to us, but it very much depends on that planning process as to how they can configure that space and what the opportunities are. So at this stage, I can't give you a definitive list, but certainly we would look to offer as much as we can from that particular venue.
I'm sure Rosie wants to come back.
Yes, thank you, Chair. I just wouldn't want it to be seen as providing an alternative to the George Bryan Centre.
No, yeah, absolutely. It is a community provision. It wouldn't be an inpatient provision. It would be the community, absolutely.
And have we looked at the possibilities of what we might use the George Bryan site for in the future?
I believe that's outside of the scope of what we're discussing, so I can't comment further on that. Helen, I don't know if there's anything you want to add.
No, that would be subject to a separate process once we've concluded the process for the inpatient services.
Rosie, back with you.
Sorry, going on a little bit. Yeah, just one comment that at the moment, the current position is that any of the patients requiring any sort of appointments attending the sexual health clinic at Robert Peel Hospital. This doesn't seem an appropriate place for anybody to go. Much less people that have got a mental health issue. And I just wanted to make sure that everybody was aware that, we just feel that this is totally inappropriate.
Thank you for that feedback. We'll liaise with MPFT around that.
Thank you. Just let me just check around the room whether anyone else wants to come in on this specific point. Can I just ask when we're likely, Nikki, to see what the scope of services proposed is? I understand your planning point. Some planning authorities turn around planning applications on the drop of a 9-bob note, and others take a bit longer. But when do you anticipate having planning to be able to share with us? Because arguably it builds on the community services, because you're talking about day services, aren't you? Because you're not talking about inpatient, you're talking about day services. But when will we get that better overview, holistic overview?
So I'm hoping, as the councillor previously referred to, as it has been a previous NHS building and delivery was from there, that it will be it won't be protracted, but I don't have definitive dates for you, Chair, so I'll need to clarify those, and we'll provide an update with that alongside following the standard operating procedure for the transport policy as well. So I won't make a guess at that. I'll make sure I get some detailed information.
Appreciate that. Thank you very much. That's helpful. I think that concludes that element. So aligning proposals in line with the mental health strategy, bottom of 98. I'm sure we all welcome that. This strategy we might see at some stage, this week, next week, sometime never. Actually, I'm told it's coming in December. So welcome that comment there. On to the next page, page 99. I think that broadly takes us towards the end of the report. So in terms of next stages, I note 4.3 says that you're currently going through NHS E&I or NHS England assurance process, and maybe you're able to update us once that has been concluded. Do we have a date for when assurance is happening? Helen, with you.
Yeah, so we had a really useful meeting in September with NHS England in terms of feedback, and we also updated them in terms of the feedback that we received from committee on the 1st of August. So we wanted to reflect upon that, and we are intending to hold the assurance panel middle of November. So we're anticipating that we will come back to you. I think the next committee of yourselves is the end of November, so we would come back to you with an update there.
Brilliant. I think we all note that and welcome that and look forward to that information. I don't think there's any further indications from this side. So Helen and Nikki, thanks for your input this afternoon to committee and to the responses provided so far. We note there's a couple more things still to provide and we welcome those when they come. And we'll see you in mid-December. Otherwise, thank you for that. We note the report. And I think that brings us on to item number 8, which is the exclusion of the public. I have no reason to exclude the public because there is nothing else to do. However, I just wanted to comment on one other thing, two things. We'll see the mental health strategy some stage between now and Christmas. Hopefully it is a joint strategy across health and care. And I would encourage anyone who is over 50 to grab a jab in the meantime, and to encourage your residents and fellow councillors to also grab a jab and make sure that our winter is less difficult than it might be. Otherwise, thank you for your attendance this morning, and I wish you a good rest of the day.